Hello, dear colleagues, dear doctors. I'm very pleased to give lecture today in this online form. My name is Olga Emelianova. I'm dentist, orthodontist. A little bit about myself. I am the speaker for Align Technology. So here is this disclosure that everything I would tell today is my own experience that I've encountered during the work with clear aligners. I want to introduce myself, to talk about myself. Unfortunately, I could not see you, but I hope that there are doctors among others with whom I'm personally acquainted, and also many new colleagues with whom I would be very pleased to get acquainted on offline. For those who don't know me, I'll tell you a story of my professional life. And maybe that will give you more information and you will understand why I'm telling you about the clear aligners and about their application in my practice. I'm very pleased that aligner course that is provided by August is provided by different speakers, especially speaker from Russia, because I'll be talking about the experience of using aligners in our country. I graduated from Moscow State Medical Dental University in 2005 with distinction, and I didn't think by that time that I would connect my professional life with working with clear aligners. But actually I want to emphasize that in Russia, in orthodontic education, there is no any part about the use of aligners. So in 2005 I didn't know anything about this type of treatment, but in the whole world, in US, in Europe, I knew that aligners were quite widely spread and were introduced in orthodontic practice, not so popular maybe as brackets, but also they were quite popular in dental offices. Then I had 1 year exchange program at Stony Brook Dental School in Long Island, New York, where I was really exchanging the experience. I was watching, I was studying, and it was my first point where I found out that there was some kind of alternative to the fixed appliance. Then I came back to Russia, and in Russia clear aligners were not presented yet. So I've finished the residential. I have a specialization in orthodontics, and I started working as an assistant with American doctor who came once in a month, bringing aligners in his case. And that's when I first time I could see how it works on patients. I'm a very curious person by nature, so it was the first time I've seen it's in progress in work. It's very important not only to see, not only to hear, but also to try it. So then I had my PhD. It's also in the field of orthodontics, and maybe my connection with university finished. Since 2011 I left university, and this became the starting point of my very tight work with aligners. In 2011 in Russia, the company appeared, distributor, that gave possibility to work with Invisalign. And I became clinical director, the doctor, not who also was studying but also the doctor who taught others. The main idea about aligners, that aligners, they also apply virtual planning as a main part of the work. So when you can calculate the stages of treatment, the more precise you will do it, the less unpredictable will be the active treatment. So from 2011 I started to work with aligners quite a lot because it became possible in Russia. So the product was certified, and also I was teaching other doctors. And that required a lot of studying for myself. From 2011, I'm a speaker for Align Technology in Russia, and encountered a lot of experience from, and I keep on sharing with it, and I keep on working and keep on sharing because I didn't finish my clinical activity. Right now, I'm working in 2 clinics, and one of the clinics is completely oriented to treat patients with aligners. So patients who come into the clinic, they already know, and they want to know about this technology and to be treated by this option. And I'm very happy that more and more patients are learning about the alternative. When I started in 2011, and my colleagues who started with me, there was a lot of skepticism, not only from the patient side, but also from many doctors. But everything is going forward, everything is developing, and we are working with aligners very successfully. And even in Russia, we have got a rich experience which we like to share. This is a little bit about from my professional steps as becoming a doctor, and I'm a diamond provider, and I have more than 200 cases a year, and I keep on being a diamond provider for many years. I'm also a mom, wife. I have 3 children. I'm very happy that they support me in my developing my professional evolution, and this is my support. And but I want to tell about people who influenced me as a doctor, my mentors with whom I spent a lot of time, and I also to give credit to them and to thank them, because these are people, who gave me a nice foundation in my education, especially in aligners. First of all, this is Monse. This is the first person which I started to work with whom I was started as a clinical specialist. So for becoming a mentor for other doctors. Monse, this is a doctor. Yes, she's not a doctor, but she knows a lot about the software. And she managed to know the program, the software, much better than other doctors. So the software, the ClinCheck, is developing very quickly, very dynamically. So that's what doctor has to take into consideration, and she gave me a lot of insight about the software. Also, Wikim Volasklich, doctor from Australia, who was in the she's from the foundation of the company. So she performed a lot of research with Dr. Boyd. She was working on mechanics of moving teeth with aligners, and she's very nice specialist from the academic point of view. She can structure the knowledge. She helps to understand and to fully grasp the idea. So from her I have this kind of foundation, also the basics, and I'm very grateful to her. And of course, Dr. Andrea Bazuki, this orthodontist with a very vast experience. He started to work much earlier than us, and he already had a lot of experience by the time we got acquainted. But also, it's my colleague. For many years, we were working together, and thanks to him that I widened the range of application of aligners in my practice, and I also became using more complex approach in treatment of patients. And seeing his results, he's Italian, he thinks about aesthetics. For him, not only the harmony of position of the teeth is very important, he is also takes a lot of time to create the smile aesthetics. So he gave me a lot of also information and insight, and I thank these people. But we are moving forward, and I want to tell you some about the structure of my lecture, about our outline. So the name of the lecture is quite vast. I was trying to give you my experience on different clinical examples. So I will tell it a lot of time today, and I will go back to that many times. So what are the main tools to work with aligners. So it's software, attachments, and protocols of treatment. Knowing this and taking this into consideration during the planning, you will get nice, stable, reliable results. Your treatment of patient would be smooth and easy. So I try to gather different clinical cases in this lecture. I hope it will be very interesting for the beginners and for experienced doctors. I don't know, webinar is a one-side communication. I hope that our clinical examples and their process of treatment will be interesting for many doctors. And of course, making the virtual setup, virtual planning, then you're moving forward with the patient just to get less troubles. You have to meet a patient, to have also control, and you have to, if you see any problems, you have to deal with them immediately. So our outline will cover a lot of topics, and each part could be a separate webinar by itself, but I hope that you'll find very positive moments for your own work. I'll start with this scheme. There are two counteractions. What is more effective, pushing or pulling? And this is a counteraction that we see in two systems of orthodontics, because brackets are pulling, aligners are pushing, and so there are different opinions about what is easier, what is more physiologic, what is clinically more effective. But for you and for me and for doctors who work with aligners, it's very important to take into consideration and to know the basic principles. And what are these principles? That aligner is first of all, that the aligner could create the push on many surfaces. So we have unlimited pushing effect, and this is the advantage you can use. It can push on occlusal surface, on a buccal, on lingual surface at the same time, and it creates the force that is required for the realization of the clinical movement of the tooth. Aligner could provide separately the root of the crown, or it can create also some kind of pressure on the crown, and it depends on what you need, and you'll realize it also through the material that the aligner is made of, because aligner material is also a very important part in the treatment with clear aligners. So the software, it changed a lot during even my experience of working with it. So from 2011 in Tandem, I've noticed how dynamically the program changes, how many new functional options appeared, and right now I'm very happy that I could perform these movements by myself. I can place attachments, I can move teeth, I can change the inclination of the root of the crown, I can work with the dental arch by itself or locally with some segments. I can place the elements that I need for the realization of the treatment. So the software, the ClinCheck, this is your tool, your instrument with which you're working, and where you can form the customized individual treatment plan that you discussed with the patient, and according to which you will move forward. And of course, aligner system we couldn't even imagine without attachments, because attachments are special surface on which there is pressure, so it will be directed, and that is required for the realization of the movement. Attachments will increase the surface of contact of aligner with the tooth. In some cases, it's important just to get rid of the arrow and to increase the clinical reliability, and we'll talk about that on different clinical cases. Also, this is additional anchorage for the tooth movement. The very important advantage that in a software, in ClinCheck, you can move the teeth was stay in sequence. You can block the position of the teeth and use them as an anchorage, so you can prevent moving of the teeth if you don't need it, and that can customize the approach and will be the foundation of the tooth movement, and also will influence the clinical predictability. I want to go in the past, to go back in time to my first clinical case that I've performed many years ago, 2010. A little bit about Sergey, who came to me with a complaint about his aesthetics, but not to me, but to general dentist, who sent him to prosthodontist, because Sergey complained about the aesthetics of his anterior teeth. So he's an adult who never thought that he would need orthodontic treatment, but he always wanted to have beautiful smile. He's a sportsman, adult, and of course braces for him did not encourage him at all to be involved in the treatment. He has very severe wearing of the anterior teeth, and as we called reverse smile arc. So anterior teeth they're eroded and they lost part of their height and form. So this is a clinical situation of Sergey, his edge-to-edge bite, and it will be very hard to make prosthodontic treatment in this position because it required a lot of invasive treatment from the prosthodontist. And of course, we're not talking about the restorations of the teeth, direct restorations. Also, Sergey has bruxism, so all restorations would not be long-lasting. That would require the complete reorganization of the teeth position. This is 2010. So this is the case that I was not taking on my account. I was doing it through the doctor I was working with. So the doctor who brought the aligners in his case, but for his luck, as I understand it right now, he was orthodontist. I mean, my mentor. So the planning was very nice quality, no problems at all. But by then, maybe I was not thinking at some moments, and now I just gave impressions and said that we need to prepare a patient for the prosthodontic treatment, and I was not taking part in the treatment planning. It's very good that we have pictures and I can go back in time and maybe to rethink my approach again. I'm doing it sometimes, often or not often, but I'm doing it. So this is OPG of Sergey. You see wisdom teeth on upper jaw are missing, and there are wisdom teeth on lower jaw. Of course, right now I would start with extracting of these wisdom teeth, but by then I didn't think that there are some kind of interference for the treatment, and they are guilty of creating some kind of inclination that have to extract them. But right now, first of all, in most cases, I'm for extracting third molars, not only for the space, but also from the point of view of stabilization of the clinical result. The treatment of Sergey required 35 aligners. We didn't use additional aligners, but there was an option like that by that time to finish the treatment with ideal result if we received some kind of difference from virtual setup. So by that time the aligners were used one in 2 weeks, and patient was very motivated, very disciplined, and that's what we've got. These are the pictures that were made after the prosthodontic treatment, and it was restoration with a composite material, and he was very pleased. The dentist was very happy. I was happy too, and right now maybe I would plan the treatment differently, and I would make the finished result much better because it's possible. But just in the end, we finished the treatment. For me, this first case is very important because it encouraged me, and with my own hands I felt that this system is working. Sergey, he managed to get very nice aesthetics. That's was his main goal when he came to the dentist, and with this result we are potted. But this is the past. Sergey has very nice smile, stable smile. He is attending general dentist regularly. He is using removable retainers. He feels comfortable in them during the night. He is still doing sports. His muscle tonicity is quite high, so that's why it's easier to him to sleep with retainers. So it's quite stable result. I've seen him a lot of years before. I just have these pictures, and preparing for this lecture, it was interesting to me to see what is going in Sergei's mouth 10 years after the treatment. So let's get back to the future, to the present time. What changed? Of course, first of all, technology changed. Working mostly with aligners, with Invisalign aligners, I'm witnessing how dynamically this system develops. Once in a year, once in 18 months, we see the update of the program. We see that the function becomes better of the clinical applicability. We see much more options and much more components in this system. And of course, I have more knowledge, and that's the reason why my approach to treatment is a little bit different. I want to show you Lily. She's 40 years old. She has class 3 tendency. She has crowding, crossbite between anterior teeth. Lily came to us referred by her dentist because she has crowding, and that was her complaint by that time. She has narrowing of dental arches on upper and lower jaw. We see asymmetry. We see class 3 molar relationship. And after the CBCT, I could visualize the bone condition around the teeth. So we could not treat her with proclination or with the change of the torque to the positive buccal torque. Here we had to preserve the relationship of the root with the bone that we had before the treatment, so we couldn't make this relationship worse. So in case of Lily, we decided to perform sequential distalization for creating space. Sequential distalization, this is the most predictable protocol of treatment with aligners that can give us to use aligners as an anchorage. It can give us the possibility to sequentially add teeth and move them distally and getting space to have the required movements that we needed. So this is a difference of aligners from the fixed appliance, that you can block some teeth during the treatment and you can perform their movement only then when you need it. Also, I want to emphasize, please, with the grayish color, we pointed to 7. According to the patient's preferences, we didn't move this tooth. She had periapical lesion and she didn't want to extract this tooth. There are patients who do not follow all the recommendations, unfortunately, so this inflammation lesion was not very big. We were following it, we were controlling it. It was in a chronic state, but we decided not to move this tooth. So we didn't need any major movements of this tooth, so we just blocked it, and it didn't influence the movement of other teeth because on upper jaw we didn't require distalization. So, and we managed to change the relationship by the movements of the lower teeth. So quite a lot of time is required for sequential distalization, but at the same time this is a predictable protocol for the teeth movement. Total treatment time 51 aligner, but one more thing I want to point out, that upper teeth, we started to move only on the aligner 32. The quantity of active stages depended on the volume of movements. If we perform distalization on one jaw, it will increase the number of aligners. On upper jaw, we just needed 19 aligners for all the movements that we needed. From the aesthetic point of view, so the patient was using aligners on lower jaw, and she was using upper aligner only on the upper jaw during the night time for the anchorage for elastics, and during first 32 aligners, aesthetically nothing changed in her life because teeth on upper jaw didn't have any attachments. We placed them later, and so for her there was no any additional stress. So in cases when we perform distalization in lower jaw, I do this. So for the optimization of the treatment process, this is another additional advantage for the patient from the aesthetic point of view. And I'm moving teeth just an amount I need. Then we are transferring to the retention phase. New attachments that were placed on buccal teeth. There are special elements that control the torque of incisor roots, class 3 elastics, and attachments for the teeth for anchorage. Even on tooth 7 that we didn't move, I placed attachments for getting the anchorage during the use of elastic. You see that interproximal reduction. So it was performed quite big, but we still had black triangles because we had quite severe atrophy of the bone even before the treatment. It's very convenient to analyze using the tool the complexity of tooth movements. You can use the table or to use these markers on virtual models. But when you are satisfied, you can order the aligners. This is a staging table, so how on different stages the teeth are moving. On lower jaw, you see sequential distalization. The protocol 1/3. It means that each other tooth would start the distalization after 30% of movement of the first tooth, the most distal tooth. This is the sequential distalization protocol that I used a lot. It's quite reliable, but it requires a lot of attention towards controlling of the patients, how nice they follow your recommendations. The earlier protocol is so 1/2, so half protocol 0.5 when you move each tooth on 50% before you're starting moving the mesially placed tooth, but it's even more prolonged treatment time. Class 3 elastics. So elastics, this is the anchorage that we need during the teeth displacement. We'll add elastics no later than we start moving the second premolar, because we see the decrease of amount of anchorage teeth. So this displacement of the second and first molar will be due to the work of aligners. Then we need additional anchorage like elastics. In case of using them in sequential distalization, I prescribe to wear them 12 hours per day at night and several hours before the sleep or after the waking up, but we have to follow this 12 hours protocol. We placed rectangular anchor attachments on molars. Lily has very nice big crowns of the teeth, but nevertheless, additionally, I placed attachments not to have displacement of aligner on upper jaw, because elastics would be held on precision cuts, so the force would be on the whole aligner. It can lead to its displacement. So anchor attachments are not part of the protocol. I have to follow and to place them by yourself. In all the cases, I add them if we didn't, of course, have optimized attachments. And lingual root torque of the lower incisors. This is the must, because during the aligning of the crowns we have to express the torque, so to get the better relationship of the root with the bone. So it's a function that be automatically placed by the program, but you have to make sure that it exists, that if you plan to protect the root, so that you need a power reach so for expressing this kind of movement. On the aligner 23, I want to show you how we can realize clinical movements. During the treatment, I make a lot of photos, and it's very useful even for yourself just to have a look and to analyze what is going on. We created space, so we performed the distal movement of the buccal teeth. We have the spaces distally from the canines on the lower jaw, and we still have crossbite between anterior teeth. You see that we didn't change anything on the upper jaw because the treatment of the upper dentition would start only in 9 aligners. So all this time she was wearing upper aligner only for using class 3 elastics. We placed 2 attachments on second molars just for the better retention of the aligner and for the possibility to use as an anchorage. So 12 hours a day she was wearing upper aligner. All other time she was 24 hours a day was using lower aligners. Very important stage that we have to check. It's how then the fit between the aligner and the teeth. See that aligner 23 very nicely fitted in the mouth, so all the movements that we planned they were realized. By the end of the main treatment course, we needed additional alignments, refinement, but by that time we normalized the position of the teeth. We had a slight disocclusion. In a fourth quadrant, tooth 4-7 required the correction of the crown torque and little crowding of anterior teeth. For that, we ordered 8 or 9 aligners. 9 aligners that were used to get nice intercuspidation. And here all the teeth are moving at this simultaneously. There is no point to divide upper and lower aligners because they were equal amount on upper and lower dentition. Take notice what happened besides attachments. We have cutouts for the buttons for vertical elastics on the molars, on the teeth where we didn't have optimized attachments. We placed traditional attachments. When you perform the movement of the molar because of the moving because of the using of the elastics, it will be realized completely. Aligner fixing of the anterior and posterior teeth would realize this vertical plant movement. So elastics were required here to minimize and not to get any mistakes during the movements that we planned. Vertical elastics that I would use here is 1/8, so it's average force 3.5 ounces. Traditional attachments rectangular, placed vertically, they would get very rigid fixation of the aligner on the tooth. And once again, control for the movement of the roots, just not to get recessions, not to get any complications. This is a final result. Of course, Lily became much brighter. Her aesthetics is much better. It was not the major goal, but her smile is becoming broader. So we corrected the occlusion. Right now she needs to work of general dentist, the restoration of some teeth, but we have a nice form of upper and lower dentition. We corrected the torque of 4-7. We didn't move tooth number 2-7, and the lesion remained, but this is the choice of the patient. Informed consent from her part. The main thing that the position of the lower incisor that during the treatment didn't become worse, and the condition of the bone is the same. So this is Lily's example, and I think that if Sergey would come to me right now, I would choose the treatment with extraction of the lower third molars and distalization lower jaw, but there are different treatment approaches, different treatment plans, and the technology changes and knowledge of the doctor also changes. Well, working with distalization is the most predictable tool. I want to tell you about a story of my other patient. Anastasia, she's 27 years old. She came to me having quite a big experience of orthodontic treatment. She already had 2 orthodontic treatments with fixed appliance. 2 times she was wearing braces. And when she came to me, she said that she doesn't like her aesthetics, she doesn't like the protrusion of her teeth, she doesn't like her smile. So she has severe protrusion of upper and lower incisors, narrowing of dental arches. You see a class 2 relationship on right side, class 1 relationship on left side. Severe proclination, if we judge it according to the face aesthetics and according to the jaw positions. It's very sad to see her enamel, because we see that her teeth encountered twice the removal of the braces, and we have scratches on the teeth that we can do anything here about them. So we see still narrowing of dental arches, we see rotation of molars, we see space deficiency in posterior region. So what is required for getting successful distalization? In case of anesthesia, I plan the treatment with distalization in upper and lower dental arches. First treatment was without extraction of wisdom teeth. The second treatment was with extraction of wisdom teeth, but nevertheless it didn't get to the successful result. We see uncontrolled tipping, there was not enough anchorage, and that is the result that you see. In her case, I decided to treat with this distalization in upper and lower jaw. The main key point for the successful distalization on aligners is, first of all, this extraction of wisdom teeth. Of course, to perform distalization is not effective. There are teeth that are not following the doctor's or advices. They're not extracting class 3, extracting with the third molars, and we start distalization even with this teeth. But planning the teeth, you have to planning the distalization, you have to be sure that teeth would be extracted by the time the treatment would start. Here is the article about the position of the attachment. The protocol of attachment placements would be depending on the amount of movements, what kind of tooth movement you need, and that is a reason to choose the proper attachments. But if you see that molars do not have attachments in ClinCheck, it's better to place them, because it will decrease the amount of intrusion in distalization and would increase the clinical realization of the distal movement of the tooth. What do we need? We need anchorage. From the point of view of anchorage, we need elastics, class 2 elastics if we perform distalization in upper jaw, or class 3 elastics if we're talking about the distalization in lower jaw. Elastics that would minimize the reaction on anterior teeth. Also, for that we can use mini screws for not influence the teeth of other jaw, because when we use elastics, nevertheless we have some kind of influence on both dental arches. Additionally, TADS mini screws could get less errors with quite more frequent change of aligners. Of course, very important part is timing. For getting effectiveness, patient has to understand that the liner has to be worn 20-22 hours per day. In that case, the treatment would be effective. In case of elastics for anchorage, they need to wear it 12 hours a day. Also, that would make them effective. And then we can control the days of changing of the aligners. As a rule of thumb, I start with once in 14 days for adults. If I see that the patient is responsible, he's following the recommendations, and the aligners are very nicely fit, we are going to the change one in 10 days. In case of using TEDs, we will switch to once in 7 days or one in 5 days, because we'll get rid of the reaction on the teeth, and we would get the possibility to change aligners more frequent. And these options are very important when you plan distalization. Let's go back to the treatment plan on the anesthesia. So we planned the tooth movement. sequential distalization with anchorage on lower dentation, class 2 elastics, the protocol of distalization 1/3. So when we move 3 teeth, we'll have spaces, and it will be the inclination and retraction of the upper teeth. As a standard, as a rule of thumb, optimized attachments on the teeth, on the molars. On the second molars, you see traditional attachments that we need to anchorage, class 2 elastics. And you can take notice the amount of retroclination that we wanted to get in 41 aligner. On lower jaw, we planned the interproximal reduction of enamel. So we can see the amount of tooth movement on the table, so how distally the tooth was displaced. You see 2.5, 3 millimeters of molars. And I want to show you what you have to see when a patient comes to you for the checkup, because patients visit us once in 3 months. For that period, we are given aligners. We are calculating the amount of aligners. We can correct the frequency of checkups, like for example once in 2 months. So this is a aligner number 19. So where they had distalization of the molars, the premolars are moving, so the second molar is stable in its final position. What is important to check when the patient comes to you? It's very important to visualize that there are spaces, that the contacts are open, and the aligner is very tightly fixed on the teeth and attachments. So it tells you that the clinical realization is complete, is full. Also, we have to compare the stage of treatment that the patient is having right now with a virtual setup, and so how true it is. So if a liner is very nicely, tightly fitted, and that means that the treatment is going according to the plan. It is her final result. We managed to make the teeth movement, so we corrected the inclination, the tipping, the dental arch form. So we corrected the curve of Spear. We have class 1 occlusion on both sides, and right now Anastasia is using her retainer at night, removable retainers. So there is no need to use fixed retainer because she has very tight intercuspidation, and she doesn't have any moments that would require to hold the anterior teeth in their position. I want to go back in time. I want to show you one more case from her earlier history, early career, and to compare with what is going on right now during the diagnostics and treatment planning for my patients. 2011, Natalie came to me with aesthetic complaints. She didn't like the diastema between incisors, also has spaces between other teeth. Natalia is a patient, and there are many patients like that, who didn't even think about treatment with other appliances. She didn't know about aligners, but she was sure she would not wear braces, and maybe she would not visit me if by that time I wouldn't tell to all my colleagues, right from now on I'm working with aligners, and you can inform your patients, and then I'll be working with your patients by myself. So that's how I started to see patients that were never thinking about being an orthodontic patients. She has already attrition, teeth wearing. You see the decrease of the occlusal height between posterior teeth. We see spaces between teeth, and I didn't take notice about this severe wearing, severe attrition of the teeth. Right now, if Natalie would come to me today, I would have different treatment plan. She has Bolton discrepancy, so lateral incisors are smaller than they have to be. That's why we have this extra space. Besides, also the decrease in height. So what was the treatment plan? It was one of the first patients that I started to treat by myself via my account. We used 28 aligners. By that time, her treatment plan was orthodontic correction with the IPR, we could change the perimeter of lower teeth. There was slight crowding, but for closing upper spaces we needed more space. Of course, attachments. She didn't use any elastics, and after 28 aligners we used 10 additional aligners that were leveling the final position of the teeth. I still have these pictures of the CleanCheck. Unfortunately, I could not load the file with the CleanCheck. I found these photos in a folder of the patient. So quite a big stripping on the lower jaw, quite a big IPR. I think right now I wouldn't use this option if I would treat her today. We didn't extract wisdom teeth, and that limited my ability to work with curve of spear on lower jaw, but Natalia, she didn't know that, and we were treating her with aligners. It was successful. We managed to close the spaces. We made better aesthetics. We normalized the teeth position, but we didn't influence the height. So in the posterior region, you see that the height it changed a little bit, but you already see that there are not enough cusps on molars, and we have to restore them. Also, there are wearing facets like that on premolars and canines. But by that time, I was not pointing my attention to that. My colleagues also maybe missed it, so we were not working with the height. So Natalia went to the retention period. I didn't see her for several years. Everything was stable. Then she dropped out from the control, so I couldn't tell you anything about her destiny. But right now, when I see this attrition in my patients during the first consultation, already discuss it with the patient, I'm deeply concerned that the treatment would be successful if it would combine treatment with the help of other specialists. Only then we could get to the functional and long-term beautiful result. What is going on today? Today, I treat patients a little bit differently, and here I want to tell you about Tatiana. Tatiana, she had the experience of orthodontic treatment before me, but she came to me that she didn't like her aesthetics, position of upper teeth. She's not satisfied with her smile. She doesn't like diastema. She has severe deep bite, traumatic occlusion. You see that a very big curve of spear because of not enough support in the buccal area. The relationship of canines is class 2. You see inclinations of the teeth, also wearing of the incisors, and most unpleasant thing that she has severe attrition of the crowns of the teeth. You see their anatomic form is completely distorted. There is not enough support from the posterior teeth. That is the reason for deformation of the position teeth in the anterior region. So we discussed with her during the first consultation that her treatment would need also the restore of the occlusal surface of the teeth. For her it was new information, and she had to adjust to this third. But she was quite reasonable, so she understood everything. These kind of surfaces, of course, they are quite, you see, they are already quite destroyed. And many patients read blogs and know after they treat with aligners that the teeth are not in occlusion. Very often we're not taking into consideration the anatomic form of the teeth. It's very important to warn the patient from the beginning that after the treatment these teeth would not be in occlusion because they're not having anatomic forms, they don't have cusp, there is not enough surface to perform the chewing function. Her CleanCheck, also there are teeth that we didn't move because of their general conditions, I mean the health of these teeth. We planned asymmetrical distalization only from the right side to get space and to change the inclination of the anterior teeth. We changed the dental arch on lower jaw. We were working on dilatation, expanding, and also getting rid of the proclination and also the flattening of the curve of Spear. Here, by the way, her movements is like round tripping. Then we do leveling, so they go into proclination, and then we are correcting this proclination. Attachments, class 2 elastics for anchorage during the distalization stage, and IPR, interproximal reduction. Also, we had bite ramps to get this occlusion between posterior teeth. Why do we need it? So to have more effects on the movement, on the derotation and inclination of posterior teeth, so the patient wouldn't have any desire to squeeze the teeth and to get the intrusion by this parafunction. Also, these bite ramps, that will give me the sufficient height and will get also kind of some kind of better condition of the muscle activity, a relaxation of the muscles. Also, IPR, we needed to decrease the black triangles and to get effective intrusion. 32 aligners were planned. Protocol of distalization is 1/3. Class 2 elastics 24 hours a day, because no matter that the distalization was from one side, we need to relax the muscles and to also to try to get a lot of knowledge to get used to the new position. Rectangular anchorage attachments on posterior teeth for not displacing the aligners, because she was wearing a lot of elastics, and bite ramps for getting the height between posterior teeth to exclude the squeezing effect and more effectively move the buccal teeth. This is her final result after the orthodontic treatment. Here you can see that we normalized the inclination of the teeth, the form of the dental arches. We flattened the lower curve of Spear. The relationship is class 2, but at the same time we see symmetrical form, the sagittal in sagittal plane, and also we went back to the necessity to restore posterior teeth. Unfortunately, not all the time patient is following the recommended treatment plan. It's not necessarily the wish of the patient or not enough understanding, maybe some kind of external conditions, for example, financial situation. But so by that time, Tatiana declined the additional treatment, for example, restorations of the teeth, for example, with a occlusal onlays on the teeth, but we have to rehabilitate her anyway, and we have to preserve the result and have to get in retention. So we decided to make the restoration with a composite material on posterior teeth. Let's get back to the initial situation after the orthodontic treatment and after the composite restorations. So we restored molars, premolars for getting the height and the support for the buccal teeth. After restoration, due to the height that we managed to get, we transformed to the class 1. She was more comfortable in this position because during the treatment she got used to this height because of the aligner thickness, because of the bite ramps and class 2 elastics. And during this stage, we let Tatiana go. Small restorations that they're not so long-lasting as ceramic restorations, like ceramic onlays, but as a solution, as an immediate solving of the problem, this could be, and we can successfully use it in some cases, but it has limited time of warranty. And right now with this nighttime retention, aesthetically she is completely happy. She has a wide, broad smile. She is not disappointed with her teeth inclination, and by the height that she get, we see the change of the profile of the lower third of the face. So once again, if we compare two of the these cases, we see the change in my approach, but also in general, the technology helped us to move forward. According to some authors, deep bite is one of the most prevalent malocclusions, about 51%. For our area, it is like that. Many times, patients comes to us with deep bite, with deep overbite, and Tatiana also is one of the old early patients that are treated many years ago. So Tatiana came to us with aesthetic complaint. She has completely 100% overbite. There is narrowing of upper dental arch, lower dental arch. We see negative crown torque of upper incisors. We see crowding, almost crossbite on the left side, and we see a rectangular form of the dental arches. During our first consultation, she had 3 wisdom teeth, and we left all 3 wisdom teeth during the orthodontic treatment. On lower jaw, we use them as an anchorage for pushing from them to normalize the torque and the width of the dental arch. To work with tipping control of posterior teeth would be impossible because of the space deficiency, so it preserved a little bit on upper jaw the same situation. During the active treatment, we let this 3rd molar, but later I would send her for the extraction of this tooth. First, she extracted lower wisdom teeth and then upper wisdom tooth. You see the inclination of the incisors, class 2, division 2, and this is her treatment plan. Very important moments when you work with a deep bite, when we want to normalize the curve of spear. This is the protocol of the torque changes of anterior teeth, the change of the width, and you see that wisdom tooth is not moving, so it only serves as an anchorage. So the form of the dental arch would be more effective because we need expansion, we need to have some kind of anchorage for making this push, and to also to rotate the teeth and displace them. What is important to analyze the movement of incisors, because for more effective teeth movements we have to follow the protocol, and we'll discuss it a little bit later. But we are going along the way of analyzing the teeth movements. In Tatiana's case, 40 aligners. We see a sequential change of the inclination, then intrusion, retraction of anterior teeth, elastics, IPR. You see the space deficiency because we left wisdom teeth as an anchorage, so we couldn't treat it any other way. So we perform IPR on upper jaw to get nice relationship attachments. I think she had them, but I don't see them in this treatment plan. Strange. So here is what we've got. This is the final pictures of the smile. So we increased the arch width, the broadness of the smile, so the smile became better. She had more vertical support, so her profile changed. We see the change of the lower third of the face. Maybe right now I would send Tatiana for the for correction of the gingiva, because it requires to see a little bit less pink in her smile, and of course in case of the change in of their angulation, of course they erupted a little bit more, but it's not enough, so we need to work with gingiva a little bit more. We managed to decrease the overbite. We see class 1 relationship of a dental arch form, and we're extracting wisdom teeth. We extracted first lower wisdom teeth, then upper wisdom tooth. So right now she's using removable retainers during nighttime, and here you nicely see that aesthetics changed a lot of the dental arches, of the soft tissues, but we could work a little bit more, so only the hairstyles stayed the same. Profiles became better because we have more vertical support in posterior region. Another patient, Polina, she's 20 years old. She came to us with a severe deep bite with big narrowing of the arches, see negative torque, the crowding. Dental arches, they're very narrow. And once again, let's take a look at the clean check. Well, when we have to work to correct the deep bite, you can plan the intrusion of lower teeth, upper teeth, or intrusion on both arches. But you have also having a negative torque to restore it first. Here you can visually see when we work with lower dental arch, first we perform that proclination, so we restore the torque, then intrusion and the displacement of the posterior teeth. Once again, posterior teeth, they will be first as an anchorage, so they will not be moving simultaneously from the start of treatment, and that's how you can maximize the clinical application of aligners. When we normalize the perimeter, then we can start the movement of the posterior teeth as well. So we could block the second molars. We could do the movement on correction aligners, on additional lines, but you have to analyze the situation. If there are wisdom teeth and you don't want to move them, you can use them as an anchorage. The amount of intrusion is possible with slight overcorrection, but do not do it too much. So don't do from deep bite the open bite, because clinically it won't happen. This is a final result. So Polina was very smiling person before the orthodontic treatment, and she has quite a broad arch, but from the point of view of the dental position, we have very nice support on posterior teeth. We have very nice overbite between anterior teeth. We normalize the torque of upper teeth, of lower teeth, of relationship between the dental arches. The only thing that we had the bite plane effect, so there is a disocclusion between posterior teeth. So in general, it will get to the nice intercuspidation during the nighttime retention if it was the consequence of the wearing of aligners. And Polina is using nighttime retainers. When you plan teeth movement, that you have to think always about the way the force would be applied. To work with anterior teeth, so to get the retraction, to get intrusion first, you have to create a proclination. So we have to restore the crown torque. So it's all started from proclination. So we displace the crown buccally. Then we perform intrusion. When the torque is restored, then intrusion would be according to the vertical line of the tooth, so vertical axis of the tooth. It will be more natural to try to perform proclination and intrusion. At the same time will be not effective. You have to divide these two tooth movements. If you need retraction, you do it as a next stage. Retraction and intrusion, it's better to do with a control of the position of the roots. So I have to add lingual root torque, not to get the arrow, to control the displacement of the root. Also, taking in consideration the staging of this treatment, so proclination, intrusion, and retraction, the correction of the teeth by deep bite will be more effective. If you plant retraction, it will also be clinically predictable. In general, it is considered that open bite, if it's a dental-alveolar type, this is the easiest malocclusion to be treated by aligners, because it happens that I've told before, this is a bite plane effect of the aligner itself. Besides the actions that we planned, this is uncontrollable action that patient unconsciously trying to squeeze the teeth through the aligner wearing. So intrusion of the posterior teeth is more effective. And when we need to correct the open bite, it will be as a side effect that we need for the treatment goals. So for the treatment of the open bite, we use extrusion movement on anterior teeth and intrusion force on posterior teeth. We're using light forces, but anterior teeth would be displaced as one unit to get the vertical overbite, but as a side effect, the posterior teeth would be moving vertically, and here, besides the action of aligner, will also have the effect of the bite plane. There is an article that compares different forms and position of attachments for extrusion. Of course, without attachments, the extrusion would not be possible because aligner need to grab something to get these vertical movements. There are doctors that successfully can use palatal attachments for extrusion. This is very good from the aesthetic point of view. As about me, I don't like it and I'm doing it very rarely. I motivate the patient to use the buccal attachments. We have to take into consideration the surface of the lingual area. The flatter the surface, the easier would be to place the attachments. It will be traditional, conventional. For retention, it's enough. If the surface of the tooth is curved and there are a lot of deep curves that would create so-called forces, that attachment position would not be effective. The aligner would not be able to grab the crown of the tooth, so we'll get an arrow in extrusion level. That's why attachments are required. I want to show you a case of Daria. Daria came to me with crowding, with open bite. So she has crowding, she has I say not enough overbite, but there is class 1 occlusion on the right and left side. You see that not correct torque, not correct position of the teeth, and the form of the dental arch is elongated, triangular. As a treatment plan, not so many aligners, only 12. What we planned here? So we planned extrusion of upper teeth and change of the forms of dental arches, change of the rotation of the teeth. So the extrusion could be for upper and lower teeth. And the last stage is a jump. This automatically would be shown in cases when you plan extrusion and intrusion at the same time simultaneously during the wearing of aligners. It would be simultaneously. During the virtual plan, it will be like one jump. So on a teeth where we perform extrusion, we see extrusion attachments. So all incisors on our upper jaw and central incisors on lower jaw. Also, we plan to use class 3 elastics to control the teeth movement on lower jaw to avoid buccal tipping during the derotation and aligning. And that's it. Posterior attachments, control on the lingual displacement of the roots, 12 aligners. No IPR here. We know that a aligner can affect simultaneously on unlimited amount of tooth surfaces. So vestibular extrusion attachments are in top priority. She would have their rotation of the anterior teeth, correction of their angulation, but because of the action of the wall of the aligner on different surfaces, that would be possible without attachments. Extrusions are in priority, and you could not replace extrusion attachments. So this is the element that we use by default when the system analyzed that you planned extrusion. Attachment has a big surface, so the bevel surface would be towards the force that is going vertical, and that's how you'll realize the movement. Daria, by the end of treatment, we normalized the overbite. Also, the relationship is the same, and the upper and lower dental arches became wider. And one of the easiest malocclusions with aligners, very quickly, effectively. Of course, it's required to have cooperation from the patient and retention. So we have to analyze why this open bite happened. We move on. So right now you'll see cases of crowding, treatment of crowding, and crossbite as one of the consequences of the crowding. Katerina, she came to us with crowding, with aesthetic defect, and here it is not only because of the teeth position, but also because of a lot of restorations and odontically treated teeth like lateral incisors on upper jaw. Of course, they would require the restoration. They would require, I think, ceramic veneers to get the nice aesthetics. But first of all, we need to have the stage of orthodontic preparation for the prosthodontics. Crowding, space deficiency for the canines, and also decreased size of lateral incisors, class 1 occlusion from both sides. And you see some dental history, a lot of fillings that require correction, changes, but before the treatment we didn't have any teeth that required treatment right now. So what we're performing during the orthodontic treatment, we need to create space on upper and lower jaw, because no matter that she has narrowing of the arches, the width we could get by the restoring of the angulation, it's not enough. So we planned for a patient distalization that could be performed simultaneously with a change of the width of the dental arch form, distalization in upper and lower jaw, sequential distalization. The only thing that on upper jaw we need more distalization than on lower jaw, because we have severe space deficiency for the canines, correction of the crossbite, correction of the overbite between anterior teeth. And normalization of the dental relationship. Quite a big amount of attachments. Attachments not only optimized, but conventional attachments, attachments on lateral incisors that are required to increase the contact surface with the tooth, because the tooth is quite small. So we need to support vertical control. We see bite ramps on anterior teeth of the upper jaw. She has class 2 elastics with the use of the buttons on the canines for getting simultaneously with the tooth displacement and anchoring for distalization to perform extrusion of the canines. Very nice tool I use a lot is Chekhov occlusal contacts, to analyze contacts before the treatment and after its finishing. 37 aligners. In average, it's 1 year of treatment, a little bit more. Depends on the following of the recommendations from the patient side. As I've said recently, it's very important that we use button cutouts for the buttons, just that the application of the elastics would be towards the crown of the tooth. Then it would work for extrusion and for creating the anchorage. In cases when we could perform this cut out only for elastics, we'll see the accumulation of the arrows and we'll see less clinical realization. On lower jaw, she has cutouts for elastics, so it will be the action on the whole aligners. So we need anchoring attachments to contradict displacement of the attachment from the lower jaw, and bite ramps are required to get the height during the correction of the deep overbite. These are the stages of treatment, so we analyze that the stage in the mouth is according to the treatment plate. See the aligner number 16, sequential distalization. We see opening of the space. We still didn't correct the crossbite between anterior teeth, but we're creating space. We use aesthetic buttons, and she uses them to put class 2 elastics. So the spaces are equal to, and they coincident with the treatment virtual setup, and the liner is fitted very tight, so that could lead us to the continuation of the treatment and approaching the final result. After 37 aligners, we managed to get result. We corrected the overbite, we created space, we moved canines, but there are still some need of corrections. We still have the crowding on lower jaw. We need more tighter contacts, and we need to close space distal to the canines. So we made an order for additional aligners, 6 aligners. They are directed to get tighter intercuspidation between posterior teeth, to close the spaces, to correct the canine positions. Here we perform simultaneous displacement of all teeth. We use attachments. We keep on using elastics from the buttons, class 2 elastics, bite ramps to decrease the overbite and to increase the height between posterior teeth. In this final result, Catherine is smiling widely, but she's not used to her smile. She didn't do veneers yet. Then we'll have the stage of the prosthodontic treatment, change of fillings, and by that time we leveled the careful spear, created space, displaced teeth. We managed to get tight intercuspidation and sent her with temporary retainers to change fillings, to treat teeth, and to create aesthetic veneers. So you see the form of the dental arches, the position of the teeth. This is treatment plan for Ekaterina. Another example that I want to show you. This is Ivan. Ivan also came to me with a crossbite. His tendency to class 3, crossbite on lateral incisors, crowding on lower jaw, also crossbite on molars on the left side. Quite a big crossbite. We see the wearing of incisors and space deficiency on lower jaw. Narrowing of the upper jaw and more rectangular on lower jaw. This is a rotation of molars and space deficiency. And of course, for Ivan, it was required to extract wisdom teeth because we needed to get space, and this is the space that I use for displacement of the teeth. Very important step working with a ClinCheck is to check the bite, the relationship, because you can make pictures with the wrong angle, but you have to understand that after the loading of the data that the relationships are correct. For 6 years I use an iTero scanner, but nevertheless I check what I've got as a virtual data before the start of treatment. We perform sequential distalization on lower jaw and also we change the form of the upper jaw and upper dentition, and we move the lateral incisors to the dental arch. Sequential distalization takes a little bit more time, so the movement of lower incisors would start a little bit later, but from aligner number 14 we start to correct the crossbite because the lateral incisors of upper jaw would be displaced buccally, and during that time the software would just superimpose tooth on tooth, so the tooth is going through the tooth. Clinically you will get premature contacts, edge-to-edge position, and disocclusion between posterior teeth. Here we use class 3 elastics because we need to control the control of anterior teeth, of incisors. We have to help with distalization, and it's about elastics. There are certain things that are concerning this case to get better clinical predictability. You see, extrusion attachments, they are required on the tooth 1, 2 for the vertical control. So we didn't plan extrusion, we planned the buccal movement of the tooth, but with buccal movement, because we are applying the force on the crown, we could get the side effect as a proclination. So we can decrease the movement of the root and to make the fit of the aligner worse and not to get the adequate tooth displacement. So this extrusion attachment would control vertically the way the teeth would be moving. Elastics in this case, class 3 elastics, I would be applying as a cross elastics from the palatal side of upper molars to the buccal surface of the lower canines. This would be required to help with expansion in case of the point application. So when we put elastics on the button, so we are transforming the force to the tooth directly. The elastic force, when it's going to the buccal surface, naturally it will do the narrowing, and when we apply the force from the palatal side, it will promote the expansion. So it will control the form of the dental arches. It depends on where you place elastics. So the palatal button for the elastics help to increase the perimeter of the dental arch to get better relationship in the second quadrant, and we corrected the crossbite on premolars and help in control of the incisor movement. The crowding she had before, so we use the space that we've got from the distalization, and we didn't have any errors. We didn't have side effects as proclination of the incisors. Let's take notice about the intermediate phase. This is aligner number 14. When we buccally displace the crown of the lateral incisor on the upper jaw from the right and left side, we have to check the fit, that the aligner is fitted nicely and is fixed with attachments. So the buccal movement, the crown and the root would be displaced together. So it is very comfortable to wear aligners. Right now for the patient there are several points of contact, but when the patient removes the aligner, he would get contacts on the teeth that are in the stage of correction of the crossbite. So during the treatment on a virtual clean check, we see that all teeth are in contact and just lateral incisors are going through the lower teeth, but clinically we are getting disocclusion between the posterior teeth. From the recommendations to the patient during this stage, so to wear aligner as much as possible, and if the patient is responsible, I understand that he's following my recommendation according to the protocol. He's wearing aligners 20-22 hours a day. I look at the clean check. How many aligners we need to correct the cross bite? For example, from 12 till 17. When we normalize the overbite, and during these stages I give to the patient right to you to wear aligners less. So if to change them in 7 or 5 days, not in 2 weeks, to get the overbite as soon as possible, and then we're going back to the proper timing of the wearing of aligners, because in that case patient would feel less discomfort during the mastication. And this is the final results of the smile. Very nice form, very nice arch width. We created space, we created overbite. Of course, it is required to correct the incisal edges, because during the use of these teeth, they are a little bit changed. You see, they lost their incisal edges. We get better relationship from the right and left side. Made them better. Right now they work with prosthodontist, with general dentist, to correct tooth number 36, and restoration to make better aesthetics of the incisal edges of the teeth. Not all the time we could use the space from the extracted wisdom teeth to align all the teeth. I rarely treat with extraction, but I do extract when there are indications. There are no other options, because I'm ready to fight for every tooth. Every tooth is important, not only from the position of this position and arch, but from an aesthetics point of view. We have a lot of patients who comes for the additional treatment that were treated before with extraction of premolars, and it's very sad. Ekaterina came to me with big, severe crowding. She almost didn't smile before the treatment. She has a history of orthodontic treatment in her childhood. One tooth was extracted on the left side, and they used a plate, but she didn't permit to extract another premolar from the right side. So there is ectopic position of the canine, high position of the canine. So her work with orthodontist finished, and only many years before she came back, because she doesn't like aesthetics of the anterior teeth. She doesn't like aesthetics of anterior teeth. She is embarrassed by her smile, and this patient was waiting for the period when it would be possible to be treated by aligners. There are a lot of patients who wouldn't even think about treatment on braces, because it's not aesthetics, it's not hygienic, and it's more discomfort and a lot of more stereotype notoriety. She has space deficiency, very high position of the canine. Besides aesthetic problems, there is also problem with the bone, with the gingiva, with the gingiva contour. There is no recession, but we see quite a big atrophy of the bone between the teeth. And in her case, we decided to extract some teeth. We extracted 3 teeth, to upright and align the teeth that has to be aligned to get aesthetics and function, and to let her get more dental work. I extracted tooth 1-4. So the premolar in the first quadrant, and the second quadrant, the tooth was extracted before me. It was a lot of years ago. So we already have here narrowing of the dental arch in the alveolar process area. On lower jaw, we extracted 3-4 and 4-4. So we send the patient for the extraction before the attachment placements. In some situations, you place the attachments and then send the patient for the extraction. Virtually, the program would get the monos and scans with the teeth, and the treatment plan there is notification that they will be extracted. So we'll get the clean check with so-called Pontex. So the teeth that will be here camouflaging this defect during the treatment, so the patient would feel better. And after the teeth extraction, we start the movement to close these extraction spaces, to create the form of the dental arches, to correct the crossbite from left side, to normalize the position, the form, the width of the dental arches. It's quite easy alignment because we normalize the angulation of the tooth number 1, 3 in the direction of the closing of the extraction space. The same with the tooth 3, 3. Correcting its tipping, we also partly close the space. We see a slight round tripping. What is it? Let's see. Tooth 2 is a little bit displaced buccally during the treatment to get to let tooth 33 to be displaced, and then it will go back to its position. First a little bit buccally, then it's going back, which is called round tripping, to get space, to let the teeth movement, and to exclude the here the collision between the teeth. So I changed optimized attachments for conventional big attachments for the better retention of the aligner during the treatment. But unfortunately, I didn't take in consideration the fact that I need a precision cut for the elastics and cut out for the buttons, because elastics, you see, was displacing the aligner, because we see the displacement of aligner on 1.3 and 3.3. On lower dentition, we made one cutout for the button, because technically you couldn't make cutout for the elastics on the lingual part of the teeth, and it led to this slight arrow of the movement of the tooth 4.3 buccally with a small mistake. No matter that we extracted 2 teeth on lower jaw, we still had a space deficiency and disproportionality that required IPR. It's vertical horizontal attachments to control the teeth displacement. Right now, would I change? I would add the cutout for the button instead of the precision cut for the elastics, just to use it from the point of extrusion, so to let the force from the elastic be applied to the tooth directed. Unfortunately, even this big conventional attachment wouldn't be able to hold the attachment, so we see the step-by-step displacement of the aligner due to the elastics force, and we'll see the accumulation of the arrow bite ramps to get the disocclusion, to get vertically the space and let the teeth be displaced without any collisions. In case of the severe crowding, in case of the deformation, when we need vertical displacement, we need to get this vertical height for the possibility to vertically move the teeth. And the use of the bite in case of the palatal buttons, so we have a directed force from elastics to the tooth to get it into the dental arch. This is the stage when we placed attachments and sent the patient for the extractions. She extracted 3 teeth. The extraction was quite easy if the teeth are in dental arches. We don't have any complications, so after several days the patient could start the use of aligners. In aligner we can create aesthetically pontic, so artificial tooth, so the patient won't feel discomfort during the use of aligners, and there will be no aesthetic complaints because of the absence of some teeth. We placed attachments, not all the buttons left, and I'm still hoping to use the precision cut for the aligners to get extrusion of the teeth 1.3 and 4.3, 1.3, 3.3. That's what we've got by the end of this stage of treatment. We used 37 aligners. We made an aesthetic better. She started to smile. Actually, she changed a lot her hairstyle, so each treatment stage is connected with different colors of the hair. She changed the crown because she didn't like the appearance of the tooth. What is very good, because we have STL file with information about the form of the tooth, so we can make the crown for the tooth that will be identical in form and size of the tooth, and that it will be suited for the aligner, so we don't have to stop and make it order for additional alignments. As soon as I started to have arrows because of the tooth displacement, I placed the button and made the button cut out, so I was cutting each aligner to decrease the arrow that was accumulating here to get the maximum effect from the displacement. When we lose the fitting of the aligner to the tooth surface, the attachment could be interference. So I removed it, placed the button, and then placed it back and started to work with the displacement of the teeth. We almost closed all the spaces, but we're still working. It is still the treatment is in progress. We needed correction. We added additional aligners, and during this stage, we let her go to the prosthodontist. You see the normalization of the position of the teeth, the overbite. We flattened the lower curve of spear. Unfortunately, what I could not correct because of the anatomic conditions is the black triangles between the teeth because of the bone atrophy. It is between the high position of the canine, so she has black triangles on the left side as well, but in the first quadrant the black triangle is much bigger, so it will be the work of the prosthodontist to close it. So we normalized the position of the teeth, we displaced them, we rotated them, we managed to have a nice intercuspidation, and during the temporary retention we sent the patient for the prosthodontic treatment. Crowns, change of fillings, and then a final retention. In some cases, we have to deal with missing teeth, and this was agenesis of the patient, Daria. She came to us because it was impossible to skip appointment of in the orthodontic treatment. She came to us to be treated by aligners because for many years she had a smile that was okay for her because she avoided broad smile because there were problems with the teeth, and she waited until she became 38 and she preserved deciduous tooth. This is her relative aesthetic in the first quadrant, but you see its condition. The roots are completely destroyed and the crown is still in the arch because she was not masticating on that side, so there was no any load on this tooth, and she restored this tooth as a Maryland bridge. So the general dentist fixed the composite on adjacent teeth to fix the restoration. There was no possibility to place implants because of the space deficiency. There were not enough conditions for the implants, and she didn't want to wear braces. So that's why she came for the appointment, for the consultation, with the question: is it possible to make the correction with aligners? She already had crowns. She had the bridge on the lower jaw. You see the crowns on 3-7, 3-6, they're splinted. We had to separate them. We have to extract the deciduous tooth and to remove this Maryland restoration on upper jaw to get the space and conditions for the surgeon to place implants and then to make implant prosthetics, and it will be aesthetic result. According to the OPG, we see fresh extraction of the wisdom tooth. It was not easy, but if she decided to be treated, so she decided to be treated completely. It's about creating of the space on upper jaw due to the distalization, so teeth displacement. It's not pure distalization, it's distal tipping to restore the vertical position of the molars, and lower jaw uprighting of the molars and correction of the premolar position to get the space for the implants. a treatment plan. In general, quite an easy situation, but 45 aligners. Here we see that the tooth is missing, where there was no Maryland bridge anymore, so there is space, but we need to work with posterior teeth and for making aesthetic of anterior teeth better, to get the relationships better and contacts. We need quite a big distalization. On lower jaw we do distal uprighting, movement of the premolars, mesial movement of the tooth 3-5. It requires less stages of treatment than on lower jaw. See, 35 on upper jaw, 30 on lower jaw. Attachments, elastics are very short, as you can see, and in general from other side I will also prescribe short elastics, but on crowns we placed big attachments. There were no space for elastics. On the left side it is required not only for the creating the anchorage for the distalization, but also for helping to mesially move premolar. Aligner number 30. So active aligners are finished on upper jaw. We still work on smile aesthetics. So we open the spaces on upper jaw, on lower jaw. There is still process in progress of finishing of distalization, and we are in process of correction of the anterior teeth. But we see that there are spaces that are present between 36-37, between premolars, and active stages are finished, and during the passive stages nothing would be changed. So we decided to order additional aligners on lower jaw for normalizing proximal contacts and closing the spaces that are present. Upper aligners she was continue wearing on from the first set, and we didn't change anything in them. The main goal is to close the proximal spaces that are still present here. That required 10 aligners, only 2 attachments, and were placed elastics because she is continue wearing them for the movement of the upper teeth. There is no movement on upper jaw, this static model on the stage that we already have here. And this is a final result after the finishing of treatment. She is smiling widely, she has broad smile, and no matter that she doesn't have crowns on implants, this is the stage of treatment she will have to undergo in the future, but there is no dominance of canines, no narrowing of the dental arches. We open the spaces for the implant placement, and we normalize the occlusal contacts between posterior teeth. Quite an easy treatment from the point of view to get the proper inclination of the posterior teeth, to open a space for the implant placement, and we made the aesthetics better, and we made better occlusal contacts on the teeth that are present. Then it will be the work of oral surgeon, prosthodontist, and so right now she will use temporary retainers to just stabilize the received result. Michael, 27 years old. He came with aesthetic requests. He didn't like crowding. He was telling stories that he'd never smiled on his wedding pictures, and he came to correct his smile. He is a physician, a doctor, so he is close to our activity. He is cardiologist, but he didn't like the stereotype of treatment with braces. Very deep bite, severe crowding on lower teeth. Lingual inclination, area of the upper jaw, class 1 occlusion on both sides. But the former dental arches are very narrow. Very narrow. So the first clean check was very optimistic, 18 aligners, and the treatment was comprised from normalizing the form of upper and lower dental arches. It will let us align the lower teeth, and we will work with curve speed, performing intrusion of lower anterior teeth, and a slight uprighting by the buccal display movement tipping of the teeth will increase the height. 18 aligners, so it's quite a quick treatment. On some teeth we placed attachments. We didn't use elastics here. Let me see. On the attachments for control of the teeth displacement, power ridges for correction of the torque of the roots, and white ramps just to let posterior teeth to move buccally and to avoid bite plane effect. I've noticed this before, and I will tell you how to avoid this bite plane or bite block effect. I use it almost for all the patients that have a deep overbite, and overjet permits to use bite ramps. I have only good feedback. I know with a lot of opinions from many doctors who use aligners. In my hands, they work very nicely and see positive effects from them. They could be on incisors or on canines, depending on the overjet, and they could create vertical height. So an aligner patient could not squeeze tightly buccal teeth, so we will avoid intrusion because of the clenching on teeth, but it also can maximize the planned movement of the posterior teeth that you had on your virtual setup. When the patient removes the aligner, he has tight occlusal contacts, so it would have this disocclusion and not enough tightness of the contacts without aligners. Also, to get this bite block effect, bite plate effect, I would create artificially red occlusal contacts on premolars and molars. So I will ask the technician to send me clean check where we have this red tight occlusal contacts on premolars and molars, or I can move it by myself in the 3D control tools just to see that the teeth would be in very, very tight occlusal contact. Timing. In some cases you just have to wait. For example, for this patient in 2 months during her nighttime retention, and she was waiting for the restoration for the lateral incisors, naturally teeth get intercuspidation. If you don't have posterior crowding, and that is not the reason of the disocclusion between posterior teeth, these tools would very successfully help you to deal with these problems. So getting back to Michael, so we received a result. The result is more or less quite aesthetic, but we still some kind of see inclination, crowding, and curve spear is still quite severe, quite curved, and posterior region the relationship is almost the same, but we managed to have a slight expansion, but we need to order additional aligners. And this is the case when additional aligners, there are much more than number of initial aligners. It happened in my practice, and I show this situation on this example because we did not work with posterior teeth. We still have presence of the posterior crowding because we didn't perform uprighting, and the space we managed to get during expansion is not enough to correct this occlusion between posterior teeth. That's why we'd use different protocols for the teeth movement. Right now we'll sequentially we perform uprighting of the teeth, and this is a process that would take more time than just a change of the form and perimeter of the dental arch. So the main course of treatment would be shorter than the course of additional aligners. That's how we can work with curve speed to flatten it and get space not to get posterior crowding. And this is a final result after the treatment. So we restored a little bit anterior incisor because it was flattened. We flattened the corpus spear, managed to get a tight intercuspitation, and then we fixed a retainer on lower anterior teeth, and the patient decided to continue treatment to change the fillings, restorations, so the creation of the anatomic form of the teeth. This is possible. So we're going back to the question of planning. So what is important is a treatment plan, but please do not forget about the patient. When we already give him aligners, we place them, and we doing clinic checkups. It is in general we prescribe, of course, the checkup once in 3 months. If you never had mistakes, it means you never will encounter success, because in my practice there were some mistakes, or some mistakes led to the prolongation of the treatment, but it led me to the need to share information, and in that case you will have less moments, less problems during the treatment of the patient. On Michael's example and on other examples, the treatment process is based on the daily control of the aligner wearing. Patient has to wear aligners daily, and when the patient comes to appointment, you have to compare the ClinCheck virtual plan with the actual situation in the oral cavity. If it is consistent with each appointment, it means that the treatment is going on according to the plan, and the patient is very nicely cooperating, and clinical realization will be very high. If something goes wrong, use auxiliaries, and it's quite normal. There are different options to use auxiliaries, but you can choose whatever you need. The patient has to understand that a aligner would be effective if he keeps on wearing, and you have to check whether the aligner is fitted nicely, so you can have nice realization. It doesn't matter on which aligner the patient came to you, have to analyze the fitting of the lines, not only the teeth that are in movement, but also on the teeth that didn't start their movement. To all our patients, we give chews. This is a rubber roll that can help you to increase the surface of pressure when the patient bites. So not all the time patient can bite on all the teeth. With the chews, it will be very effective. To compare the treatment plan with the stage that the patient came to you with, and to see that the aligner is fitted properly, and the treatment stage is according to the stage in the mouth of the patient. Auxiliaries that we could use, and here you are also limited by your own imagination. You can use them with the aligners to get the result. What we use quite often in cases when we need rotation, and quite a big rotation, like with the tooth 4-5 on this picture. It's so it has two roots. To derotate it would be quite a very hard task. So during the ClinCheck, I plan to place buttons, and the patient will use elastics to help with rotation. This is aligner 21, and here the tooth is rotated. If during the treatment I didn't follow up and I didn't plan it during the treatment, then and I see that the arrow is quite big, so the rotation is not complete, I do the cutouts, place the buttons, and the patient use elastics, or I use elastic chain. Then it will be more active tooth movement, and it's quite easy and very effective. Also, if I need some help to extrude the tooth, here's an example of the tooth that was impacted. We performed the surgical opening of the crown. We placed the button, and patient vertically we move the tooth, and then additional aligners. Of course, the use of the mini screws, that's when we have severe crowding, when we need distalization, just to perform the distalization on this big amount without additional aligners would be, without auxiliaries, would be very hard. We place two IZC mini screws, not to interfere with distalization. Patient is wearing elastics from the tooth number 4. For the canine to be displaced not only distally but towards a dental arch, and to get its extrusion, we step by step displace the teeth, and the change of aligners is 1 in 7 days. So we see step by step the teeth displacement, and right now we are starting to use additional aligners. What other auxiliaries we could use? I have a lot of tools. With these tools, I work when I need, for example, in case I need to make button cutouts, for example, or to make the precision cut so the patient could wear elastics. It's very easy, quickly, and quite precisely to make cutouts and cuts for aligners for 2 or 3 months. So there are detailing pliers, for example, to help with rotation, and also about the torque. A ground torque or root torque, quite quickly and conveniently you can create the movements. If in other direction, it will be like attachment. I think I will finish my lecture today, and I want to finish it with telling you that I tried to gather from my practice different clinical cases. I tried to show you the range of application of aligners, the way I do it, the way I believe in it, the way other doctors are using it. The dentistry, and especially orthodontics, is going towards digitalization, digital process, digital planning, and virtual treatment planning. So we have to learn it and to use in your practice, and then you will have successful work. I wish you a lot of success. Thank you for your attention. If you have any questions, you can always find me on Instagram to write to me or send me some questions or some remarks, and we'll discuss it together. Right now my lecture part is finished. If you have any questions, there is time to answer them. So I don't know how it's usually done, so I'll wait for the answers for the questions from Uliana. So we finish here. I don't see active questions. If you would have any questions later, please send them to me. I wish to have a good evening, successful work, good results, and I hope to meet you all offline. All the best. Goodbye.